Thank you very much. Excellent talk. Everyone, I think, contribute to this field, mashallah, and hot discussions. So everything been said, and this morning actually I had a patient who had a CT and right coronary was suspicious. Then I think that suspicious caused patient more chest pain, came back to me, then I did angio normal. So CT is nice, but sometimes you need to give a good information. Right, okay, thank you. My role here to again say what Dr. Harari said and then focus on ARNI. You all know about the heart failure and you know how many people suffering from this and the hospitalization and of course the impact on the burden. All these studies and of course contribute to our guidelines and you know the mechanism for heart failure. Just focus on the middle one, I think, as the most important. The left one is, and the right one, I think, is future. We've seen the HFrEF, and these are the all positive studies and impact on the guidelines you all know, from DAPA to Paradigm to Victoria, all been discussed by Dr. Harari. The most important one, these are the Paradigm, and where the ARNI had impact on the everything from mortality to the hospitalization to quality of life, and of course the SGLT2 type, all of them had a prove, the outcome both on hospitalization and cardiovascular. So then the other things discussed by Dr. Harari, these are the medication where you have, you've done your job and the optimum, you still have some limiting. You have this omecamtiv and you have this, the Victoria also discussed. And this is the new guidelines we have. We have the American one says start with the one you have more evidence base for HFrEF, which is ARNI plus beta blocker. And then you, of course, personalize based on your phenotype of the patients, or the Canadian one say the same thing. This is when you see two guidelines say the same thing, you get happy, and of course, when you see the third one, you get happier. So, of course, then Rosanna was here with us, and this is the guy who put the phenotype. We have 10 phenotypes based on their hemodynamic, on some of the lab, then you personalize your patients. But you see that most of these patients can take SGLT2 or ARNIs. What about future? I think too many medications is a problem. So if you can come with a polypill all in one, will be great. And this is what they say at the moment, 4 together. But how can we start 4 together? How to do it? This is the way it tells you. Day 1, day 2, and what to do at the end. But let us focus on the ARNI since Novartis are sponsoring this event, and this is the way the medication works, and we've seen this. We've all been surprised about this 2014. Remember when they say 0, 0, 0, 0, 0? Remember that? Okay, so it had improvement in everything. You can see on reduction of cardiovascular death, hospitalization, sudden cardiac death, quality of life. That's the most important thing. And on top of that, what we know at the moment, and this is the quality of life. Of course, we talk about nice to have increase in your years, but most important to have quality in your life, not just years. And to know the mechanistics of the ARNI is these are the studies. Okay, evaluate, look at why we get this benefit, and this is because of the working on remodeling and the ejection fraction. And that's been seen in these studies. Of course, the one important thing we had questions, why we don't start this medication in hospital? And this was the evidence to tell you about the safety of the medication. Of course, we know the efficacy, and most importantly, the safety, of course, at the beginning. Then we know what happens after the patient gets. And this is, of course, to people who are not being on any RASI or old. So this was a recommendation from the Canadian, very strong from beginning, to start ARNI from beginning, and the patient with the heart failure, even those who are not even try other things. Oh, that's HFrEF was very easy. We know that. We know the 4 pillars. What about the HFpEF? What should we do with this? This is the many phenotypes. We don't know which one to tackle. But we have the studies. We have TopCat, we have Paragon, we have Imperial, Preserved, and Deliver. All these are being kind of positive. And in the Gulf, we have, you can say 50-50, but because the study was a bit, so we have, and the seen in our studies, and these patients have mortality similar to the patient with the HFrEF. So what about Paragon? This is where we need to look at it in a different way, maybe. This is the randomized. I will not go in details of this, but what's important here, if you want to use the, ARNI in HIF-MERF, or you can say near normal, you need to be choosing this kind of criteria. So patients who are male or female, and ejection fraction at that range, normal, you can say low normal, and they have BNF, NT-proBNP is raised, and so they have all the symptoms of heart failure. The benefit, if you look at the primary, of course, you've not reached the target. You just missed it by a little bit. Now, here are the questions. Where the benefit of this is in hospitalization, and the death is not, it's not seen. But people reanalyze this, and they say on those who are urgent heart failure visit, if you including this, you will get the magic number 0.04, which is significant. And when they look at the details of this, who are getting the most benefit, the female, and the people who have got ejection fraction is around 57 and lower. And this seen not only in, so this is where the male and female. Maybe the female, actually the baseline ejection fraction, where we call it normal, is not normal. That's why they get the benefit. And this is seen actually in the first visit, in hospitalization, second visit, but not seen in a death. And if you compare Paragon with Paradigm, you see that shift. You can see where the ejection fraction, as it gets higher, you lose a little bit of the benefit of this ARNI. And what's important, we've seen it with hospitalization, with quality of life. I think that's most important in this regard. When they compare ARNI with SGLT2, you can see the similar trends of response to therapy with increasing ejection fraction. So there is tells you that there is a benefit. You will lose it at one stage. And you can see when you divide the SGLT2 into different categories, you can see you will lose it after certain ejection fraction. Again, this is a theory, behind it. Why the female get the benefit? The women have a higher, as I already mentioned, and the MP deficient state of the woman, and the menopause, and the many reasons behind. But anyway, the evidence is there. When to use this in the woman with ejection fraction even is normal. So the worsening heart failure, that's if you want a patient not to come back, outpatient, you use this medication in those near normal. And the recent, so the sooner you start, the better. Don't wait. If the patient comes to you with ejection fraction, hypertensive, LVH is there, and ejection fraction you think is normal, these are patients you can do the benefit start as early as possible. And of course, you've all seen this statement from, and it's well known to you, and this, I think, is a powerful statement that this medication should be used, should be considered on those who are just like normal or below normal. And these are the three keys of Paragon. Is use of ARNI may benefit in subset of patients with HFpEF who have lower ejection are women. Use of ARNI may be benefit beyond cardiovascular mortality, particularly among those with recent hospitalization. Key to transform medical therapy paradigm of HFpEF is to resolve heterogeneity. That's our problem with the HFpEF. We don't know. We need to really know which phenotype we're speaking about. Every landmark medication being compared to placebo, except the ARNI. But if you do that, then you get the benefit, regardless, And this is well seen, and number to treat, remarkable, is only 11, which is not seen. Of course, ejection fraction is every time we come. New guidelines give us a new ejection fraction and to tell us what is normal. That's a problem. So it's essential that ARNI and HFrEF management is superior. We've seen that to the ACE inhibitors, strong position for this we've seen already. And what's important, this one is that all four pillars of heart failure therapy have evidence to support their use in abnormal ejection fraction. More so with ARNI and SGLT2 as it gets closer to normal. This is again by the experts. We've seen this. We know that the neurohormonal problem is very high at low ejection fraction. That lots become almost like normal as ejection fraction goes up. Same apply to biomarkers, and same with SGLT2 and ARNI. You see where there is a number you see that this is the line 1. When you reach that, then you lose kind of benefit. So we as a physician, we always try to balance between improve the outcomes, manage symptoms, simplify the dosing, and increase option for the patient, and to without doing the harm, which is good safety profile, preservation of kidney function. And you can see with this ARNI, I think you can very nicely see. And this is the hypothesis. If you put everything together and you have one polypill, okay, you get not heard, I think it's 74 reduction of rate of risk, and which is equal to 25 absolute. I mean, this is not heard, of course. This is the future. Final message we talk about. We go to many things, but you only see your effect when you implement it. Thank you very much. I think we are on time. So, any questions or no questions? We go to next session. Any questions? Maybe I ask Dr. Hussein Hishmet. I think I've heard you, mashallah, you have cases on this ARNI and HFpEF. Maybe tell us, your experience of this being like what? Just, do you have a mic there? HFpEF.
Yes, I use it only in up till now. Until I have more evidence in elderly ladies. Those with ejection fraction of 50, 55,
right.
And they benefit. But you will not see the benefit immediately. It takes some time to show the benefit in these population.
Right, good. Bakir.
I will take the gear a little bit out. The European Society of Cardiology accept the ARNI as patient with resistant hypertension who have manifestation of heart failure with ejection fraction, with preserved ejection fraction.
Very nice, okay.
So this is also, it's not in the guideline, but it is, and to be honest, I use it with 2-3 patients with resistant hypertension, with shortness of breath, manifestation of heart failure with preserved ejection fraction, and they have been improved too much regarding the dyspnea. I don't know the others, what they have in their experience.
Yeah. So we'll move to the third session or second session. Who's the moderator for this? Me? Who with me? Dr. Fikri Deeb, well, حيبقى نتقدم الشباب. So Dr. Fikri Deeb is the professor of cardiology, intervention cardiologist. So he will take us to this cardiovascular risk. I think this is, again, another great sessions we have with the great speakers. So will you introduce the speakers, please? Thank you.